We're going to start with Dr. Verduzco-Gutierrez. How big in scope is the problem in terms of incident rates with long COVID?
Long COVID can be something that, we know it's very prevalent, but sometimes it's an invisible illness. So people might not think that it's that much of an issue, but really can be for sure. So one thing that we see from numbers, if we look at household pulse survey, is probably somewhere close to 1 in 5 people in the United States have had to deal with long COVID. Maybe they don't actively have it. And then we know that other studies have showed that, 1 in 10 people who get COVID can have long COVID and develop something related to long COVID. So that number is, significantly high. If you think of the number of people who've had infections and the number of Americans, I think it was something like 1 in 7 at one point may have been dealing with long COVID.
And I think that number is probably higher when you consider the amount of people with subclinical long COVID who've had COVID but haven't been quite as sharp afterwards or haven't been quite as, 100%. And that number of people doesn't really get reported, but you'll talk to patients and they'll tell you they just haven't been quite right after having had COVID.
One of the things I hear that's really hard from researchers to recruit patients who've had COVID and completely return to normal, that that kind of because then people are like, no, right, you're right, I have a little bit of brain fog, or I have not been able to exercise just as much as I used to before. But maybe, and definitely studies showing that the diagnoses given maybe using the ICD-10 code of long COVID is very, very low compared to what numbers of people that have it.
Dr. Blitshteyn, can you walk us through an appointment when you are diagnosing someone with long COVID?
Sure. Well, first of all, it's important to establish that there was long COVID or there was a COVID infection. And some patients don't even realize they present to me with new onset of neurologic symptoms or conditions. And it's important to ask, how did this start? Did you have COVID before the new onset of symptoms? And sometimes it's a revelation to the patient that, oh yeah, I had COVID, maybe a few weeks to a few months before the onset. So it's up to us. And I agree with my colleagues that the numbers are underestimated because the patients themselves may not realize that the prior COVID infection is related to the new onset of symptoms that they're having. And the infection may have been very mild and hardly, visible, but we know the consequences may be significantly bigger than the original infection. So what do I do? Well, the first thing I do is I obtain a very thorough history of symptomatology, onset, pre-existing conditions, comorbid conditions, medications, and how these symptoms affect the patient at this time. Now, of course, because I specialize in autonomic disorders, I end up getting the sickest patients. So therefore, I have a referral bias. And my patients tend to be quite sick. And by the time they see me, they have already seen their primary care physician, their cardiologist, their gastroenterologist, and allergist, and other specialists. So I obtain a history, medications, I obtain their social history, which means that they're able to continue their employment, and many times they are unable to engage in prior activities. Many of my patients are actually unemployed or unable to attend school. And very importantly, there is a history of exercise intolerance, whereas the patients identify that they were able to go to the gym or run or bike, and now they can't do it. Either they're severely impaired or they can do barely a walk around the block. Following that, I get a family history because that's important. Sometimes there is more than one family member affected. And is there a family history of cardiovascular, neurologic, and autoimmune disorders? We get their thorough medication list, including vitamins and supplements, and then we proceed with review of history. And oftentimes when you go from head to toe, you know that a lot of patients with long COVID will have significant symptom burden, spanning multiple systems and organs. And it will be anything from neuropsychiatric manifestations to musculoskeletal to allergic to gastrointestinal, sleep disturbance, you name it. And then after that, we go straight to a physical exam, which always includes a 10-minute stand test, which is what, the consensus guidance from multiple societies and organizations recommend, because it's very important to establish whether there is evidence of orthostatic intolerance, including postural tachycardia or orthostatic hypotension. We know from multiple studies that at least 70% of patients with long COVID have autonomic dysfunction. So we try to assess for that. And then we proceed with physical exam, which in my case includes neurologic examination, and special attention is paid to neuromuscular exam, including all of the sensations, reflexes. Often there is a comorbid small fiber neuropathy. So it's not uncommon for our patients with long COVID to have reduced sensation of temperature and a pinprick distally and sometimes proximately in a patchy distribution. And of course, there is a cardiovascular exam, there is skin examination because patients may have rashes. And very importantly, we have to do an exam for joint hypermobility because we know that people with joint hypermobility as a sign may be at risk for long COVID, and we have more than one study to confirm this clinical finding that we see in practice.
One thing I'll add to that was like excellent. That's kind of a best practice evaluation that I would definitely say that she has going on, is that I still always want to see how and document how their long COVID symptoms impact their function and their quality of life. So especially, if they were working before, if they can't work, can they get out of bed? Can they spend time with their family? Are they having post-exertional malaise? That's something definitely in the history that I want to hear about, because we know that's a big, something that patients with long COVID definitely have, other than just regular fatigue. And especially if you think someone that may eventually need disability, it's important that we document functionality as much as possible.
For our next question, speaking on other symptoms getting lost in translation, Dr. Verduzco-Gutierrez, would you like to explain some of the similarities between long COVID and chronic fatigue syndrome? And is it a challenge to differentiate the two when diagnosing?
So I think that patients can have both. It isn't like you only have ME, myalgic encephalomyelitis, also known as chronic fatigue syndrome. I'll be calling it ME/CFS versus long COVID, because some patients, their manifestation of long COVID is a picture of ME/CFS as well, because they have, and then you have to know what are the criteria for that, because a lot of the criteria also are some of the very similar to long COVID symptoms, because they have post-exertional malaise, they have unrefreshing sleep, some of them have autonomic dysfunction, and or cognitive deficits as well. And each of those individual things can be part of a long COVID picture too. So it's kind of, I won't say, you only have long COVID, you only have ME/CFS. Kind of depends on the history. They may have both, they may have one, maybe they didn't have a SARS-CoV-2 infection, so it may just be, we know ME/CFS has been around for decades and decades and decades and can happen from other infections or other things as well. So there is, like I said, overlap. And again, it's going back to listening to the patient, listening to their history, seeing what the symptoms are and what criteria they meet.
Yeah, I completely agree. And I want to add that we have a number of studies that show that at least 50% of patients with long COVID qualify for the diagnosis of ME/CSF. So it's certainly a subtype that we all need to learn how to assess and manage to the best of our abilities these patients with ME/CSF type of phenotype. Now, I think it's also important to say that in addition to this phenotype, we have to think about post-COVID conditions, because I think this long COVID is an umbrella term that we have to make sure that we rule out cardiovascular manifestations, hypercoagulable state, autoimmunity, diabetes. metabolic abnormalities, hyperlipidemia, hypertension that can often begin after COVID infection. And then once we go through that process and we arrive at something like, well, your routine tests look normal, but the patient is still sick, we really have to go with autonomic dysfunction and ME/CSF type of phenotype. And there we have to do our best to assess and also manage the symptoms, because as you know, there are no FDA-approved therapies for long COVID, but we certainly have a number of pharmacologic and non-pharmacologic measures to treat patients with autonomic disorders as well as ME/CSF.
I'll add to that, taking care of ME/CFS before long COVID, we knew even then that about 70% of all cases of ME/CFS were related to an infection of sorts. And we had seen it with different infections, most commonly EBV or Epstein-Barr, but we were seeing it with chronic Lyme, we were seeing it with reported mold exposure, we'd seen it after Zika. So we had seen it after a bunch of different other infections before this. When I diagnose a patient with long COVID, it's exactly like we said here. It's kind of an umbrella term. So it's long COVID, but then what kind of long COVID? It's long COVID with an ME/CFS phenotype plus autonomic dysfunction with GI predominance. You kind of really have to drill it down, because only then can you devise a therapeutic regimen that may help your patient.
The last thing to know is, one thing we know about, patients after COVID and with long COVID is that we've seen also those patients have viral reactivation. So, in bringing up EBV, then we know that sometimes after COVID, some patients have reactivation of EBV or other types of viruses. And so again, and then there's the issues that can come with that as well.